Welcome to the knee lecture for Kinesiology 280. Today we'll be talking about the anatomy and also the pathologies that occur within the knee joint. Let us start with the bony anatomy first. The knee joint itself is formed by the superior femur bone and then the inferior or distal tibia bone medially. Some people say, well, what about the fibula? However, the femur bone does not articulate or work with the fibular bone. So when we think about the true knee joint, what we're really saying is that it's the articulation or the relationship of the femur superiorly with the tibia medially in the lower limb. And then with this bony anatomy, what we also have is the patella. And the patella is really a major contributor to just increasing the angle of pull within the quadriceps muscle and connecting the femur to the tibia via the patellar tendon. The patella bone itself is a free-floating bone, and so it has different facets, which you see right here, which allow it to glide up and down the groove of the femur bone superiorly. So when we hear about knee pathologies, I think the most common type of injuries that we're going to see most often reported, on ESPN or on TV or within sports are the ligaments. The two major ligaments within the knee are number one, the ACL ligament, which is here, and then number two, the PCL ligament, which lies posterior to the ACL. And so ACL meaning anterior cruciate ligament, and then PCL meaning posterior cruciate ligament here, and then again anterior cruciate ligament there. These two particular ligaments are hugely important to knee stability. So injury or compromise to either one of those ligaments could lead to great knee instability in patients, but specifically in the athletic population. What we know about the ACL in particular is that you really can't function without one if you are athletic. And then if we move to the inside of the knee, what we also have are our major shock absorbers in the menisci, and we have a meniscus both laterally and medially. The menisci are very important in helping to reduce the amount of shock and or forces that go through the knee. And so if we can kind of look at the femur bone here, we can see how the menisci are hugely important at reducing bone-to-bone interaction between the tibia and the femur bone. And so what we would say is that if someone had their meniscus cut away, we would be concerned that this individual somehow, some way might actually develop arthritis over time, because what you would have is the femur bone either medially or laterally rubbing on that tibia bone. And as those two bones rub together, they basically rub away bone, creating an arthritic knee. And so the major ligaments of the knee, there are four. As I've stated, there's the anterior cruciate ligament, there's the posterior cruciate ligament, and then what we also have are the medial collateral ligament and the lateral collateral ligament. So medially we have the medial collateral ligament, and then laterally we have the lateral collateral ligament here. These two ligaments, the collateral ligaments, play a huge role in maintaining frontal plane stability at the knee, so preventing basically valgus and varus loads. As stated on the previous side, the meniscus and the ACL, PCL, MCL, and LCL are major contributors to stability about the knee. If there is compromise to any of these ligaments, then the knee becomes extremely unstable, and in most cases usually requires some type of surgical intervention. When I say that the knee is a hinge joint, what we're saying is that it is capable of performing functions in knee flexion, and then in knee extension, but then it also has a rotary component to it, and so what we will get sometimes are movements in tibial rotation, so tibial external rotation and tibial internal rotation as well. I think it's important as physical therapists, as athletic trainers, even as personal trainers, to really keep in mind that the knee, interestingly enough, is midway between the foot and the pelvis. And so the knee really is the major contributor to absorbing a lot of the shock and forces that are going to go up and down the kinetic chain. Remember, I said in the earlier lecture of the foot and the ankle, the foot is the first point of contact with the ground, right? And then we would say that the ankle joint itself really is good at taking all of the shock and centering it. And then we could say that our knee is hugely important in shock absorption. So what we know about the knee, because it does somehow, some way absorb a lot of the shock, that it's really susceptible to injury. And so the ankle joint, number one injury, and then behind that, the number two injury in the human body would obviously be the knee, specifically the anterior cruciate ligament. What you see in this figure are the bursa in the knee. So all of the black images that you see on this particular figure represent bursa. And when I think of what a bursa is pretty much like a water balloon or like a water bed that either prevents friction and rubbing of a bone against something or a tendon against something. And so the two most common types of bursa that are injured most often are the prepatellar bursa, which is this guy here, and then we also have the suprapatellar bursa, which is way up here. If these bursae become injured, the biggest concern is that the knee gets hugely swollen, and I think we'll see an image of that on the next slide. And so how do the bursa typically get injured? Typically, they get injured when you fall directly on the knee. One could imagine that if you were to just literally slide out of your chair and just fall directly onto your knee, you would expect the patella itself to get fractured. And the reason that you don't suffer from a fracture every time you land directly on your knee is because the prepatellar bursa basically explodes and releases fluid, and that fluid protects the patella from being fractured. So you can thank your prepatellar bursa for not having more patellar fractures. Sometimes with the suprapatellar bursa, what we see right in here is that when you have trauma to the distal quadriceps muscle group, so that would be this group, this muscle group right here. So we can imagine that in soccer, if you took like a knee to the quadriceps there, that the suprapatellar bursa would then release fluid content, and its main role would be to protect the femur bone so that we don't suffer from some type of stress fracture or or some type of bony outgrowth as a result of the bone contusion. So we call this inflammatory condition bursitis, and some doctors like to say, oh, well, it's just that you have fluid on the knee. And so I think as we are becoming more educated on the language, the medical language, the fluid on the knee truly comes from the fact that the bursa, in a protective mechanism, has released fluid to prevent either fracturing of a bone and or irritation of a bone. So one of the biggest questions in the medical community as it relates to meniscal injury is, why is it that one patient can return to play in a week or two, and then there are other patients that either have a longer or a slower recovery? And that truly has to do with where in the meniscus the injury occurred. And so I'll draw your attention to this figure right here. What we're looking at are the different zones of the meniscus, right? And so one's pink or dark pink, one's light pink, and then you have what we call the white zone, right? And as the color of pink diminishes, what we're saying about this is that there's a decrease in blood flow to this area. And so injuries that occur in the dark pink area tend to have increased blood flow, and they can heal themselves, whereas injuries that occur to the white area and the light pink area have less blood flow to them, and so they take longer to heal, or they cannot heal themselves. So what we see a lot of times with orthopedic physicians is in the dark pink ring of the meniscus, a physician will go in and suture that tear. However, if the tear is in the light pink section or in the white section, they go in and they cut it out, and that's called a meniscectomy. the biggest concern with tears that occur in each of these, in the white and the light pink region, is that every time you go in and you cut away at the meniscus, we have to keep in mind that we are setting that patient up potentially to develop arthritis, because remember, the meniscus is a major shock absorber. So when we cut away at our shock absorbers, what we're basically saying is that we won't have a whole bunch left to absorb the shock, and eventually what that leads to is a bone rubbing against bone. So why did she return in 2 weeks? Probably because she had a tear in the white or the light pink zone, and the physician went ahead and cut it out. Ideally, what you want are all of your patients to have tears right here in this dark pink zone, so the physician can go in, suture that tear up, and then they can return to play in about 6 to 8 weeks. But the awesome thing about this, even though it's slow return to play, is that your patient will have 100% of their meniscus left over. So the muscles about the knee, I guess we'll start with anteriorly. Anteriorly, you have the quadriceps muscle group, and as the name implies, quad, meaning there are 4 muscles within the muscle group. So the major quadriceps muscle, or the largest quadriceps muscle, is definitely the rectus femoris muscle, which is mainly responsible for extending the knee. And then the muscle that it gets talked about most often in the literature is the vastus medialis oblique. And this is the muscle that tends to get smaller or becomes weak after knee surgery. And then you have your vastus lateralis on the outside of the leg, or the lateral side of the leg. And then very deep, if you were to dissect away the rectus femoris, if you were to take this away, you would find the vastus intermedius. Not injured very often, but if your patient comes in complaining of a deep-seated quad pain, then you might suspect the vastus intermedius. On the posterior aspect of the leg, you have the hamstring muscle groups. So on the medial posterior aspect of the leg, you have this, what we call the semis muscle groups. And the semis are very important when we talk about ACL repair, because some physicians will actually dissect away and take the tendon of the semitendinosus and use that for the new ACL graft. And then on the posterior lateral side, you have the biggest or largest hamstring muscle group, which would be the biceps femoris muscle group here. As a whole, we could say that the hamstring muscle groups are going to aid in knee flexion, and then as a whole, we could say the quadriceps muscle group definitely going to be aiding in knee extension. So they are antagonistic in nature. So this brings us to the knee pathologies, and I think this is kind of where I left off during the lecture last Wednesday. I've given you 2 great articles that you could read about ACL pathologies. I just can't spend a ton of time here, although I'd love to. So if you are interested in reading on how to prevent ACL and how to do research on ACL pathologies, then these 2 articles are your go-to articles for any information that you might need. So we're going to be talking about mainly ligamentous injuries within the knee. We'll talk about some bony pathologies, but most of what we're going to talk about in this segment are the ligaments. And the reason we spend most of our time there is because, as I've stated, the ligaments are the primary stabilizers in the knee. Any pathology to a ligament within the knee, remember, will create a gross instability. And so when we have an injury, we basically kind of tweak the first line of defense. And as a result, the knee's unstable, our patient can't function like they usually do, and they may need to be braced in order to function within their particular sport. So the first ligaments that we're going to talk about are the collateral ligaments, and so medially what we have is the medial collateral ligament, which connects essentially the medial condyle or epicondyle to the tibia medially, and then you also have the lateral collateral ligament, which is here, and it's going to connect the lateral epicondyle of the femur to the fibular head, which is laterally seated right here, if we can imagine that. Again, remember, the collateral ligaments are major resistors in the frontal plane, so they are going to hopefully prevent valgus and varus about the knee. So they are the major restraints against varus and valgus within the knee. While we're here, this is such a beautiful picture of the anterior cruciate ligament and a small little pic of the posterior cruciate ligament, which we'll talk about a little bit later. It's always nice to see a live specimen because I think the ligaments look so much different than they do in your textbook. And so what you have here basically is a cadaver model. So if I'm orienting you, this is the femur. Everybody see that? And so what we have is the medial aspect of the femur and then the lateral aspect of the femur. And then the beautiful anterior cruciate ligament here. We've got some fatty tissue, so that's nothing. And then what's most interesting is that you can actually see the menisci. So there's your lateral meniscus, and then what's left of the medial meniscus here. We can kind of tell that the patient probably had a tear in the white zone, and as a result, pieces of the meniscus got torn out. What we can see is that medially, this femoral portion, this portion of the femur is going to rub against this portion of the tibial plateau. So my guess is that this patient probably had some form of knee arthritis at some point in time. So this is a real live knee, and this is what the ligaments and the tissue within the knee are going to present like. So just briefly to reiterate what the role of the collateral ligaments are, the medial collateral ligament, or as some anatomists might actually call it, the tibial collateral ligament, is going to be the major restraint against valgus. And so by valgus, I mean moving towards the midline. And then the lateral collateral ligament, or what we would call the fibular collateral ligament, is going to be the major restraint against varus, or moving away from the midline. Again, both frontal plane motions, right? So frontal plane stability. What I really like about this figure is it represents injury to the medial collateral ligament, right? So a patient receives a blow to the lateral aspect of the knee, right, outside of the knee, and as a result, it causes a tear of the medial collateral ligament. What's interesting about the medial collateral ligament, and I'm not sure if you see it, there are two bundles to the collateral ligament. The first bundle is this superficial bundle that you see right here, and then the second bundle is actually this deep bundle right here. It's a small portion of the ligament, but it's that portion that connects to the medial meniscus, right? And that's definitely different than its lateral counterpart. The LCL, on the other hand, has no attachment to the meniscus. So what's interesting is that when a person injures the MCL, typically what happens is they also injure the medial meniscus as well. So not only do you have a medial meniscal tear, but typically you also have an MCL tear associated with that, and or vice versa, because the two are connected. So injuries to the medial aspect of the knee tend to be more painful and tend to involve more tissue structures because that MCL does have an attachment on the medial meniscus. So as clinicians, not only are you going to be dealing with an MCL injury, but you're also going to be dealing with some type of medial meniscal pathology as well. Whether or not it requires surgery depends on where in the zone, the colored zone, that tear occurs. So what are the signs and symptoms of an MCL or an LCL tear? Well, the most common sign and symptom is going to be pain and tenderness along the attachment sites. So remember, the attachment sites would be either the epicondyle of the femur or the tibial plateau on the medial side, or it could be the lateral condyle of the femur and the lateral fibular head. It could also be in the joint line, so where the femur and the tibia come together, so the mid substance of the ligament as well. Some patients are going to present with swelling, but that isn't always the case. The patient could also have a new knee joint effusion, and what that's fancy for is just swelling. Okay, so some swelling at the knee joint. And then last but not least, and most importantly, would be laxity, or what we would call joint looseness, right? So remember, we said the ligaments maintain stability. So anytime you have a ligamentous sprain, specifically with a grade 2 or grade 3, that joint is going to be loosed. So you have to test the stability of the knee, and we'll talk about that on the next slide. So as you're looking at this slide, these are the stress tests of the knee to determine the integrity of the MCL and the LCL. So my question to you is which one, test A or test B, is testing for an MCL injury? And I'm hoping that by now you've said that test A would be MCL and test B would be LCL, right? These are known as the valgus stress test, okay? And then the varus stress test. And as a clinician, you can see that for a valgus stress test, your hand's going to be on the lateral side of the knee, pushing medially so that you can cause this portion of the knee to open up. And then if you're trying to stress the LCL, your hand goes on the medial aspect of the knee and you're pushing outwardly so that you can hopefully try to get that joint to open up on the lateral side. So a positive test would be looseness at the joint, spelling typo, and pain as well. So the treatment for collateral ligaments is really going to vary depending on the grade and the way the patient presents to you, but price is always a good option, right? So protection, rest, ice, compression, and elevation. If after 72 hours the swelling does not subside, the pain does not reduce, then we're going to refer and have that patient get an MRI. And then what we want to do with any collateral ligament injury is also rule out an ACL tear as well. And then if we have a grade 2 or a grade 3 pathology, we have to immobilize the structure because of the instability that's going to occur at that joint. So we want to protect it so we don't have other ligamentous injuries occurring as well. And then last but not least, if the knee is really, really, really swollen, then you want to limit weight bearing. So you could do crutches, you could do a knee brace, a wheelchair. You could do a wheelchair if you wanted to. That might be a little drastic. But these are the main two ways to limit weight bearing in a patient with a knee pathology. One of the most common ligaments in the knee that is injured is the anterior cruciate ligament, and it's the one that we most often hear about because it takes a long time to rehab following surgical intervention. So how does the anterior cruciate ligament become injured? So it's a valgus load, so we're going to say towards the midline. It's rotation outwardly of the tibial bone as well. So we can imagine that if we were standing up and we're looking at the knee, it's this twisting motion of the femur bone, and then you have the tibia going into external rotation, right? There are other ways that it could happen. Some would say hyperextension is one way that it could occur, and then the other way is with non-contact, and we'll talk about that because in the female population, this is the most common type of ACL injury that we will see. So non-contact meaning no one touched the patient, no one tackled the patient, the ACL just gave way. So in this figure we have a volleyball athlete who's going up for a spike, and then upon coming down from the spike, she actually ends up tearing or rupturing her ACL. So we have figure number 1, patient goes up for the spike. Figure number 2, patient's arm is coming down from the spike and she's getting ready to load her left knee. As she comes down from the spike, we get a valgus load and we get tibial external rotation at the knee, and the end result is a ruptured ACL. And so this is what we would call a non-contact injury because, as you can tell, she did not make contact with anyone in her surroundings. So what are the signs and symptoms associated with an ACL tear? Well, the number 1 sign and symptom is that the patient will report some type of popping within the knee. And then the number 2 sign and symptom is that they will immediately become disabled. They will roll on the ground, their knee will feel stable, and they won't be able to load that knee because the ACL is ruptured. Some people report that they feel like the knee is just going to come apart at the hinges, right? Remember, the knee is a hinge joint, and part of what holds that hinge joint in place is the ACL. And then there's definitely going to be looseness and or laxity with stress tests, and we're going to talk about those on the next slide. And in a small subset of people, you'll get some effusion, but then again, some people don't swell at all. So what's the management for a complete ACL rupture? Remember, protection, rest, ice, compression, elevation. We're definitely going to refer for an MRI. And then that next step, once we reduce swelling, would be surgery. We're going to brace it for a while, and then into rehabilitation we go for the next 6 months of our life. Not fun. No bueno. So the stress tests that are used in the knee to rule in or rule out an ACL injury are the anterior drawer test, and then we're going to talk about the Lachman's test on the next slide. With the anterior drawer test, the patient is going to be lying on their back, and then as you can tell, their knee is placed at about 90 degrees of knee flexion. And what that clinician is going to do is they're going to sit on the toes of the patient, and they're basically going to pull that tibia forward. And a positive anterior drawer test, right, would be one where the tibia slides forward or slides anterior. Slides anterior. And we can see this in a video, and normally in class I would show what that looks like. But we can imagine that as that clinician is pulling that tibia forward, it just keeps going and going and going. The Lachman's test is the gold standard for ruling in an ACL injury. In fact, I don't really ever use an anterior drawer test. What we're finding with the Lachman's test is, number one, because the knee isn't flexed as much, it takes out the hamstring muscle group and also the quadriceps muscle group, because the quadriceps are not on a stretch. And so the clinician is stabilizing the quadriceps muscle with this hand and then pulling forward on the tibia or anteriorly, right? And then the same thing, a positive sign would be increased laxity or looseness. And then right, the tibia sliding forward or anteriorly. Okay, so that would be positive as well. So what do most physicians do with a ruptured ACL? Well, the only way to fix the ACL is to surgically repair it. And typically 2 different surgical procedures are used. The most common surgical procedure is using the patellar tendon of the patient. So what the physician does is he goes into the patellar tendon and he's going to cut out, see that little, this little rectangle right here, going to cut out the center or the middle 1/3 of that patient's patellar tendon, and then that central 1/3 becomes the patient's new ACL. So it's kind of interesting, right? So the patient's going to have, really we're going to be rehabbing 2 injuries. The first injury we're going to be rehabbing is the ACL, and then the other injury that we're going to be rehabbing is the patellar tendon. Interestingly enough, what we're finding with the patellar tendon surgery is that there's an increased risk of patellar tendonitis in patients who have this particular surgery. Most latest and greatest research says that you can also use the hamstring tendons as an ACL graft as well. The jury's still out on that one. Since the ACL is one of the most commonly injured ligaments in the knee, there are lots of people, clinicians, therapists, etc., that really want to have focused on using prevention programs to hopefully reduce the number of ACL injuries in seasons, right? And so what they've done is they basically focus on strength, specifically quadriceps strength, and what we would call neuromuscular control and balance. So they are taking younger athletes in high school and in college, and they are creating strength training programs and balance training programs and requiring them to do this in their preseason. And what we've seen is a reduction in ACL injuries, specifically in females. So ACL injuries are preventable, specifically in your female athlete. So we have to identify certain factors, right? What we want to do first and foremost is really teach females how to land. And it starts with just jump landing technique and ensuring that they can land properly. For females, what we also want to do is start the balance training. And then what we know is that when we do jump training, what we've seen is a reduction in ACL injuries by about 30 to 40%, right? And you can kind of read this within the studies that are listed on the slide at the beginning of the pathology slide. So what's rehab look like for these patients? Oh man, so they have surgery, They either have their patellar tendon taken out and used, or they have their hamstring tendon taken out and used. So it's going to be a painful process for the first couple of weeks, but the big deal is getting extension back. And so what you see in this figure here is the patient working on getting knee extension. Really, you can't move further in the rehab process until the patient has 0 degrees of knee extension, or what we would call full knee extension. Once the patient has full knee extension, then we can get that patient doing more exercises. But initially, all ACL patients are non-weight bearing for the most part, right? Now in 2014, 2015, we're starting to see ACL patients walk out the door, and that just has to do with, I think, physicians not being worried about the graft stretching. Now, here's the biggest deal, right? The biggest deal is that you want to really work on the SAID principle. Remember, we said SAID is specific adaptations to impose demands, right? That you really don't want to put too much demand on the graft, because if you do, then you might stretch it too much. But if you don't, then guess what? Your quadriceps shut down and you're not applying enough stress. So now you have to work on strengthening the quadriceps as well. So with the SAID principle, we want to make sure that we're loading that graft just enough so that it can get used to the stressors, but not too much to cause another ACL tear. Right? The other thing that we want to do is we want to strengthen in all planes of motion. So we want to work sagittal plane movements first, then we want to move into the frontal plane, and then last but not least, we want to move into our rotary transverse plane movements, right? And if our patient is a female, what we want to do is teach successful jump loading technique, and then we also want to address any faulty mechanics that may have been responsible for the ACL injury to begin with. So if we're looking up here in this figure, we can see that, okay, as this person right here is doing a single limb squat, what we can see is that the knee is in a neutral position. But when we look at this female here and she's doing the single limb squat, what we see is a valgus moment at the knee. Well, remember, with an ACL injury, it's knee valgus and tibial external rotation. So this person is already halfway to an ACL rupture. So there are several types of knee braces that can be used to prevent or to protect the knee joint following surgery. What you will see in the NFL and in NCAA football is that a lot of linemen are starting to wear protective knee braces with the hopes to reduce the risk of ACL and PCL sprains over or across a season or a lifespan. And so that's the protective or preventative measure. But then you also have those patients who just had surgery and you want to protect that graft. And typically these patients are going to be wearing this type of brace here. It's a custom molded, custom fitted brace that they typically wear the entire time that they're rehabbing, and in some sports that they might wear for the rest of their career. One interesting thing about braces in general is that sometimes they tend to draw the attention of the other team. And so what we've done sometimes is not had our patients wear them during competition to avoid getting injured or to avoid basically having that flag on their back where everyone's wanting to go after them because they're wearing a knee brace. So knee braces can be beneficial and sometimes they can be detrimental, right? And one sport that I think of is in soccer and also in wrestling, where in wrestling they are trying to take out the knee, and then in soccer they're maybe slide tackling a little bit more than they normally would just to cause re-injury. So hopefully that doesn't happen to you or your patients, but just something to be aware of. The knee brace does cause more attention during competition. So the opposite of the ACL is the PCL. The PCL isn't talked about as much because it doesn't cause quite as much knee instability as the ACL. I've even had a physician say to me that a patient can participate without a posterior cruciate ligament. I had one football athlete who dislocated his complete knee, and he tore ACL, PCL, medial meniscus, lateral meniscus, MCL, LCL. And the only thing that didn't get repaired in that entire surgical procedure was the PCL. And when I asked the physician why, he said because the knee is completely stable and completely function without a PCL. He returned the next year and he didn't have a PCL and did just fine. So what's the etiology or the mechanism of injury for a posterior cruciate ligament? So first things first, let's remember the posterior cruciate ligament is going to prevent posterior translation of the tibia. So the tibia sliding backwards on a stable femur, okay? So how do we injure that? Well, first thing, the knee needs to be 90 degrees and then you have to fall on it, right? And so by doing that, you basically stretch the PCL and you cause injuries. So like the anterior cruciate ligament, the patient is going to report a pop, but the biggest difference is that pop is going to be in the back of the knee, not the anterior or front of the knee. You're going to have some swelling, but again, it's going to be in the back of the knee and definitely going to have laxity or looseness with stress test. The management is virtually the same. However, surgery 50-50 depending on the physician. So the big deal is going to really truly be in strengthening the hamstrings and the quadriceps muscle group. So as you can see here, the mechanism of injury for a posterior cruciate ligament, the knees flex to about 90 degrees and then you fall. As you fall on that knee, it forces the tibia backwards and there's stretch being placed on the posterior cruciate ligament. So the grading scale for a posterior cruciate ligament, really any ligament that we've been talking about. So grade 1, for the most part, it's going to be conservative treatment. So that's going to be your protection, your resting, your icing, your compression, your elevation, right? Swelling goes down, patient's pain goes down. There's nothing that we need to do except for wait. When they become more functional and they feel stable, we return them to play. Typically, a grade 1 will take about 2 to 4 weeks to heal itself, and that when we're talking about the MCL and the LCL, right? Your moderate grade 2, what we're saying is that the patient probably has to be non-weight bearing or partial weight bearing. So by partial, that means walking with crutches, walking with a cane. We're definitely going to brace them and or tape them, okay? To protect them during practice and competition. And if the knee is really, really unstable, the patient's swelling does not reduce itself after about a week and the pain continues to stay the same, we're going to refer for an MRI. And then the greatest severity grade is a grade 3, which is usually typically a complete rupture of a ligament. Patient, we're definitely going to say is non-weight bearing, right? And then we're going to refer for an MRI. And then surgery. So when we have a grade 3, the ACL definitely gets surgery. MCL probably with the meniscus is going to have surgery. And your LCL, it's questionable. And your PCL, it just depends on the surgeon. Sometimes you have a grade 3 or a complete rupture and the physician does not choose to repair it. So this brings us to the meniscus of the knee. And so how do they get injured? Well, we've said the MCL and LCL typically have frontal plane movement, so valgus and varus is going to injure them. We've said the PCL, you land on a flex knee, and we said the ACL is valgus with a little bit of rotation, and then this brings us to the meniscus. The meniscus is typically torn when you're weight bearing, so the foot is planted and you have rotation about the knee. So it's a weight bearing pathology and also a transverse plane pathology. It's going to involve some type of knee rotation, right? Well, the other way that you could potentially injure at least the medial meniscus is when you have an MCL injury. If it's a grade 2 or a grade 3 MCL injury, then you could definitely also have some tearing and or ripping of the medial meniscus as well, because the MCL has some fibrous attachments on the meniscus. Now, if we're looking at meniscal anatomy, a few things that I draw your attention to are the shape. And so when we look at the lateral meniscus, you will see that it's more C-shaped and small. And then when we look at the medial meniscus, it's definitely not as C-shaped as it should. And it's also larger. And the reason it's larger is because the medial condyle of the femur, right, which sits right in here, is larger. So it has to be larger to receive the larger bone. So what are the signs and symptoms associated with a meniscal tear? As with most ligaments in the knee, the biggest one is going to be in knee, what we call a knee effusion and or swelling, specifically within the joint line. Again, the joint line is that area where the femur and the tibia come together. So this space right in here would be considered the joint line. An interesting thing that some patients report is joint locking, so the knee actually locks itself. This is specific with what we would call a bucket handle tear, which is a radial tear in the middle portion of the meniscus. And then they definitely have pain with squatting, and the reason they have pain with squatting is because when they squat into full knee flexion, that femur bone really butts up against the meniscus. So if you suspect a meniscal tear, the big thing that you're going to do is refer, because the only way to rule it in is with MRI. And then again, surgery is going to be dependent on the zone that the tear occurs in. Remember, if it's in the red zone, then check, we're having surgery. If it's in the light pink zone, it depends if blood flows there. And then if it's in the white zone, then we're not having surgery, we're having a meniscectomy. So a repair is better than a meniscectomy. A meniscectomy means we are cutting away at the meniscus, right? So we're taking this piece of the meniscus out. And as you can tell, what happens is that meniscus gets smaller and smaller as we cut away, and that means we have more bone rubbing up against bone. A repair is better because the physician then goes in and he sutures, he sews this tear together, and we don't lose any of our meniscus, and we have less of a chance of getting arthritis, right? So what's the rehabilitation look like? Well, it depends. If we have a repair, that patient is going to be locked into extension for 2 weeks so that the sutures can heal themselves. However, if we have a meniscectomy, they could be full weight bearing within 24 hours and return to play within a week or so, as long as they have full knee extension. So the goal of rehabilitation is to get knee extension, increase quad strength, and improve mechanics. So some of you may have heard of this phenomenon called the unhappy triad. And I happen to think that the reason it's called unhappy is because the patient is going to be unhappy because there are 3 different structures, anatomical structures within the knee that are involved. So the first structure is the MCL, and the second structure is the ACL, and the last structure is the medial meniscus. Now, the 2 that make the most sense, right, are the MCL and the medial meniscus, because the 2 are kind of attached to one another. So what happens is the patient plants, right, has a fixed foot, and then essentially, so that planting, okay, leads to knee valgus. Either they get hit and the knee goes into valgus, essentially tearing the MCL. As they tear the MCL and we get femoral rotation, 2 things occur. Number 1, the ACL ruptures and the medial meniscus gets injured as well. Remember, we said the menisci get injured in transverse plane motions, right? And so if this happens to your patient, they not only have MCL, ACL, they have medial meniscus. So you might have to repair the MCL, definitely going to repair the ACL, and depending on where in the zone that tear occurs, you might have a meniscal repair and or a meniscectomy. And so this is truly the knee injury that is going to take a long time to heal itself, because you have to do rehab for all 3 different anatomical structures that have been injured and repaired and or left alone. As usual, I got ahead of myself, but as we're thinking about bursitis, anything that has an itis on the end of it, right, it equals inflammation. And so the most common sites for bursitis are the prepatellar, infrapatellar, and suprapatellar. So let's make prepatellar be black. So the prepatellar bursa sits right between the skin of the knee or the patella and the patella itself. So it's this guy right here. It's going to help prevent fracturing of the actual patellar bone. The suprapatellar bursa, again, remember I said it sits kind of between the quadriceps and the femur bone, so we can imagine that it's going to be here. And then the infrapatellar bursa, you can't see, but it's definitely going to be between the patellar tendon and the tibia, right? And a bursa, as we all know it really helps to reduce friction and rubbing, but it also aids to protect bony surfaces that are exposed. So what are some of the common signs and symptoms associated with bursitis? Well, local swelling, right? Because if the bursa gets inflamed, there's going to be swelling, usually within the knee, makes the knee look huge. If the bursa becomes inflamed and also infected, then you could have increased temperature. So when you touch the knee, it'll be warm. And then if there's infection, you will see redness about the knee as well. And if there's a lot of swelling within the knee joint, then obviously the patient will also be in a lot of pain, specifically pain with knee flexion. So how do you hurt the bursa? Well, apparently bursitis was most commonly seen in housekeepers. So it's called housemaid's knee because, as you can imagine, housekeepers used to spend lots of time on their knees scrubbing floors and doing household duties. And so that's where the name bursitis comes from. But the bursa is really irritated typically when you spend a lot of time in deep kneeling, right? So we could think about a volleyball player who's diving on their knees constantly or spending a lot of time on their knees if they're bumping, specifically maybe like the libero position. Your wrestlers also tend to get bursitis because they're spending a lot of time in the shoot position on their knees as they're diving. And the other way to get it would be this excessive friction from the patellar tendon, right? So if the patellar tendon and the quadriceps muscle group are really tight and it's pulling across the infrapatellar bursa, then that can also cause a bursitis. And then the most traumatic way is blunt trauma, right? So taking knee-to-knee contact, falling on a direct knee could also lead to bursitis as well. So how do we treat bursitis? Well, ice would be good. But the biggest thing is going to be compressing the area and trying to get the swelling out. And then, of course, our favorite, right, in this class would be non-steroidal anti-inflammatory drugs. So your Aleve, your ibuprofens, etc. What we do sometimes for our volleyball players more so than any other team is we'll put a pad directly on top of that bursa, then we'll wrap it so that if they land on that knee, the pad absorbs the shock and we reduce some of the irritation that might be occurring at the knee. So Osgood-Schlatter's disease, I like to think of this as, I guess, how would I describe this? This would be like that big bone or bump that you see on the patient's tibia, at the most superior portion of the tibia. Some people say that when they bump it, it makes them feel like they're going to vomit because it's so painful. So how does one develop Osgood-Schlatter's disease? It typically occurs because we as young athletes tend to suffer from overuse, right? And so we most commonly seen this in basketball athletes whose parents were pushing them to practice several times a day, and as a result, the quadriceps were really tight, and it was causing the patellar tendon to pull away from the tibial bone. The other reason that we see this most often is repetitive jumping. In our younger adolescent athletes and or patients that we might see. That repetitive jumping, again, loads the quadriceps muscles, and as a result, it causes the patellar tendon to pull away from the tibial tuberosity of the tibia. So what is Osgood-Schlatter's disease? Well, it's the apophysis, okay, which is a growth plate on the tibia. And what it is it's traction or a pulling of the patellar tendon. So when we're looking at this MRI, what you will see here, let's anatomically get our bearings. So we have medial femoral condyle, we have our patella here, right? And then what we have are tibia. And so what you can see, if you can really look closely, is the patellar tendon here and its insertion onto the tibia. And so what you will see is that as the quadriceps, let's imagine they're here, if they're really tight, they pull on the patella and the patella pulls on the patellar tendon. And what you get is that tiny fracturing of the tibia off of the tibia and moving with the patellar tendon. It's very painful, and it's similar to Sever's disease in the heel, where the Achilles tendon pulls away from the calcaneus. Now, typically, this manifests itself in the teen year, so around 13 or 14, and then it goes into adulthood. The only fix for this sometimes is surgical intervention. So what are the signs and symptoms? Well, I can tell you this, it is definitely pain, or what we call tenderness to palpation at the tibial tuberosity, and sometimes swelling, but more so what you see is an outgrowth or increased bone on the most anterior superior aspect of the tibia. The patient definitely has pain with jumping and stretching of the quadriceps muscle. So jumping, because as you land in the jump, it causes a stretching of the patellar tendon, and then stretching of the quadriceps obviously causes a pulling on the patellar tendon, thus pulling away the fractured bone as well, causing more pain. So how do we treat this? Typically what we do in our adolescent individuals is we remove them from the activity. In some cases, what you have to do is you actually have to cast the patient. So you actually do like a full leg cast to avoid any knee flexion activities. In our older population, so if we have a patient who's a collegiate level athlete who's had this, then what we do is just ice pre and post. And then we work on strengthening the quads and the hamstrings. There is this pathology called Larsen-Johansson's, which is very similar to Osteochondritis disease, but it occurs on the inferior pole of the patella. So here's the patella here. It's occurring right there, right at the tip of the inferior pole of the patella. So just as painful, but just not as common in the human population. Here's a great figure of the two pathologies, right? So we have our patellar tendon here, inferior pole of the patella. What you can see is a fracturing off of the patella there. Or if it's Osteochondritis disease, remember this is your tibial bone here, and what you see is as the patellar tendon inserts on that tibia, if the quadriceps are super tight, you get a fracturing away of the tibial tuberosity. Both very painful, if I didn't mention that, by the way. So the next pathology is Osteochondritis dissecans, or what we would call an OCD, or in some cases maybe even a loose body. And so with this particular pathology, what happens is you have a partial or complete separation of articular cartilage. So that's the cartilage that would be lining the bones. And so the mechanism of injury, they say it's unknown, but what we do know is that people who have meniscal injuries and who have a meniscectomy and have bone rubbing up against bone, what we see is that because that bone rubs up against the bone, the cartilage begins to wear away, and you get what we call an OCD or an osteochondral defect. And so it's very important that as we refer patients with meniscal pathologies, that we're asking our physician if they can repair it versus cutting that meniscus out. There are other ways that patients can develop osteochondritis dissecans. One of the ways to do that would be a direct blow, and typically that occurs maybe to the medial aspect of the knee, of the femur bone, where maybe the blow is so forceful that it causes a fracturing of the cartilage lining the bone, and as a result you get osteochondritis dissecans. So what are the signs and symptoms of osteochondritis dissecans? Well, swelling seems to be a sign and symptom for all knee pathologies. And then what you really get is not this sudden sharp pain, but what you get is this dull, achy pain that's constant throughout the day. You get point tenderness over either the medial or lateral femoral condyle, depending on where that osteochondritis dissecans occurs. And then if there's a loose body, what you will get is definitely catching and locking of the joint. And the patient usually comes into the clinic and they're like, oh man, like my knee's stuck, and then they'll like move it a little bit and they'll be like, oh, that feels so much better. And the reason it feels so much better is because in that movement, they probably cause the loose body to shift into a different space, and as a result, they get more knee movement. Some physicians call this joint mice, right? So just fractured bones that move around and wreak havoc within the knee. So what's the management? Rest is good. But honestly, in your active population, if their knee continues to lock and it continues to catch, physicians will sometimes go in and shave down the bone or resurface the bone, which is a chondroplasty. In other cases, what they'll go in and do is they may have to drill into the bone to stimulate more bone to grow. So this is the catch-all phrase for any knee pain that is unexplainable, okay? So this is Patellofemoral pain syndrome, or PFS. And basically what happens is there's a maltracking of the patella in the femoral groove, right? And so what we said, if we went back to the anatomy section, is the patellar bone sits within the femur bone right here up top. And it kind of, as the knee flexes and extends, the patella will move within that femur groove, right? Well, sometimes what you have is you have the vastus lateralis muscle, which is here. If it's tight, super tight, what it does is it causes the patella to slide laterally or to the outside of the knee. When this happens, the patella does not track like it normally does, and as a result, it makes more contact with the femur, and it causes tons and tons of pain. Some would also attribute vastus medialis oblique weakness to patellofemoral pain syndrome. And what they say is that if the vastus medialis oblique is weak, it cannot pull the patella medially, and as a result, that patella slides laterally as well. So you could have a tight vastus lateralis, or you could have a weak vastus medialis oblique. Either way, it's not good because the patella is allowed to track laterally, and it makes more contact with the bone, causing pain. Now, there's this thing listed here called increased Q angle, right? And so I'm going to define what Q angle is on the next slide. So what is the Q angle? Well, the Q angle of the knee is basically a measurement of the angle between the quadriceps muscles, so this quadriceps muscle here, so the rectus femoris, right? It's also, and the patellar tendon, right? And so what does it mean? Basically what it tells us is whether or not the patella itself is aligned within the knee joint, right? And if that angle is increased, what that means is you have increased pull of the quadriceps muscle, and as a result, basically, if that vastus lateralis muscle becomes too tight, then what you can get is patellar subluxation. So the normal Q angle for men is about 14 degrees, and then for women is 17 degrees. So men equals 14 degrees, and women equals 17 degrees. And that kind of has to do with the fact that women actually have wider pelvises. And so anything outside of this, then you're concerned because it sets the patient up potentially to develop patellofemoral pain syndrome. So what they say is, in order to improve this angle, then you must work on strengthening the vastus medialis oblique, because that will then again help to centralize the patella within the groove of the femur. So some of the signs and symptoms associated with patellofemoral syndrome, number one is that the patient will report tenderness to palpation on the lateral aspect of the patella. So when you touch the outside of the patella, they're going to jump off of the table. They also complain of like a deep-seated ache in the front of the knee that's really centralized. You may or may not have swelling, so this is like a 50-50 chance. But one of the biggest things that you will see and note is crepitus, that like creaky sound that you hear, that chalkboard, nails on the chalkboard kind of sound that you will hear when the patient flexes their knee and extends their knee. And then if this malalignment doesn't get corrected, then the patient can develop what we call chondromalacia, and we'll talk about this pathology on the next slide. So how do we manage patellofemoral syndrome? The biggest thing that we need to do is we need to figure out if if the malalignment is caused by weak abductors, so moving the hip out, or hip adductors, moving the hip towards the midline. If it's caused by weak hip abductors, then we need to strengthen the abductors. If it's caused by weak hip adductors, then we need to strengthen those as well. And then another thing that's linked to patellofemoral syndrome is tight IT bands. So we really need to stretch those, maybe even do some deep tissue. There are times when I have track athletes in the clinic and I'm using my elbow and they leave and they're bruised for 3 or 4 days. But their alignment issues get corrected because we've broken up the scar tissue and the tight structures that are contributing to pulling that patella laterally. In some patients, orthotics, if they are pronators, tends to work because it places the foot in supination, and by doing so, we take some of the stretch off of the medial structures of the knee. And then last but not least would be taping. Taping is my least favorite treatment for patellofemoral syndrome. And anyone who's ever had tape around the knee or on the knee joint knows two things. One, once you flex and extend it, the tape comes off. Number two, if you're a guy and you're hairy, anytime you flex and extend, that tape pulls the hair. So it's just really uncomfortable, and it's just not the best joint to tape because the tape usually does not stay on the joint for very long. So as stated on the previous slide, if patellofemoral syndrome is allowed to go untreated, if the alignment isn't corrected, then the next pathology that can develop would be chondromalacia. And chondromalacia is no bueno, and the reason it's no good is because it really does cause a lot of pain within the knee and can lead to dysfunction in your patient and the cessation of competition or participation in sport. And so what's chondromalacia, right? So it gets its name, the meaning is in the last portion of the name. So chondro meaning bone, and then malacia or malacia meaning softening. So if we put the two together, it really is a pathology where you have bone softening going on. In particular, that softening is typically happening under the backside of the patella, right? So on the back portion of the patella or the kneecap. What's the etiology? Well, it's unknown, but what it has been linked to is this idea that there's abnormal patellofemoral tracking, right? And typically what happens is as that patella is pulled laterally and it tracks, it tends to, at least the backside of it, rub against the femoral condyle on the lateral side. And that rubbing away leads to softening and degeneration on the backside of the patella. And once you rub away bone, then you get lots of sharp shooting pain that occurs at the knee joint. And again, you have crepitus as well. So what's the management? The major management would be to limit activities, specifically stairs and squatting or things that are going to place the knee in full knee flexion. Stairs because it's at the angle where the patella is in full contact with the lateral femur, and that causes pain. And then, of course, like I always say, NSAIDs, and then strengthening of the quadriceps muscles, specifically the vastus medialis oblique. If neither of these two treatments work, so NSAIDs don't work, strengthening doesn't work, then what physicians do is they go in surgically and they scrape away any softening or any bone that might be exacerbating the signs and symptoms, and the recovery is typically a week to 2 weeks. So we've talked about ligamentous injuries, and now we'll kind of go into bony pathologies. One of the most traumatic bony pathologies at the knee, besides a complete knee dislocation, would be a patellar or a kneecap dislocation, or what we would call luxation in this case. And so typically the mechanism of injury for this is the patient's foot is going to be down on the ground and or planted, and then you're going to be slowing down and cutting all at the same time in the opposite direction. It can also occur if the patient takes a hit to the superficial aspect of the anterior knee from the medial aspect, and then it causes the patella to glide laterally. So foot can be planted, or you can take a hit. So what pathologies occur as a result of the patellar dislocation, right? Because you have the patellar dislocation But then as the patella moves out of its groove, a few things happen. Number one, the back side of the patella, the cartilage supplying that patella, becomes damaged. You also have osteochondritis dissecans, so you have potentially loose body breaking off. And then the other thing that happens is you get what we call a medial retinacular tear. So that's any tissue right here holding that patella in place. As it slides over, that tissue gets torn as well. The biggest thing that you're concerned about is as that medial retinaculum, which is responsible for holding that patella in place, is torn, when we put that patella back in place, that tissue remains stretched. And so our biggest concern with the patellar luxation is really the healing and restoration of the medial retinaculum, because if it doesn't heal itself and if it doesn't go back to a shortened position, then we have the case where we have a chronic subluxing patella, which is no fun. So this is an anatomical figure which really does a good job of depicting what the medial retinaculum looks like. So if we're looking at this figure, what you want to look at is this structure right here, right? And so as the patella is allowed to glide laterally, if it becomes dislocated, this ligament gets stretched, and then what you have is basically a loose ligament that no longer provides restraint to lateral dislocation, and you have the development of chronic subluxations at the knee. And so this patient is either going to have to get this retinaculum restored with surgery or has to be taped or braced for their entire athletic career. Either way, no fun. So what are the signs and symptoms of a patellar luxation / dislocation? Well, the most common sign obviously would be what? Yeah, when we're looking at the patient whose patella is slid over to the lateral side, well, obviously some type of abnormality, some type of bony deformity, right? And then with deformity or with movement of a bone out of its resting place, then you get swelling associated with that, pain for sure, and limited range of motion. The cool thing is, in the patient that I told you about who dislocated his entire knee, he also dislocated his patella. And one thing to do for a spontaneous reduction of a patellar dislocation is really just to have that patient slightly flex their knee, and you will find that the patella will go back into its groove on the femur. So what other signs and symptoms are associated with that? Well, when any bone moves out of its socket or out of place, you automatically have loss of knee function. Particularly, you're probably going to lose a little bit of knee flexion because it's going to be painful. So what's the management? If you can't get the patient to reduce the dislocation themselves by flexing and extending the knee, then the physician will go in and reduce it himself when that patient gets to ER. I'm telling you, to save time, don't call 911. Just have them slightly move their knee and that patella will pop right back into place. Once the patella gets reduced, they're then immobilized for anywhere from 1 to 2 weeks with the knee in extension to allow that retinaculum to heal itself. If the knee is allowed to go into flexion too much, then the retinaculum, the medial retinaculum, will stay stretched and increase chance for subluxations to occur. After the patient has been immobilized, then last but not least, what we need to work on is strengthening of the quadriceps muscle, specifically the vastus medialis oblique. Some other knee pathologies that get layman terms, euphemisms that we're going to talk about and hopefully give them true medical names. The first of those is what we call runner's knee, right? And so, oh, my knee hurts. It typically is attributed to running, right? And so what's the pathology for runner's knee? Typically you see this in cross-country runners, right? So that's going to be those runners that are running lots of miles. It's repetitive, it's overuse, and there's a malalignment of typically the patella. However, it could be of the foot and of the lower limb. The signs and symptoms most commonly associated with this, or the two pathologies that are most commonly dubbed runner's knee, would be IT band friction syndrome, which occurs distally at the knee, and then you have pes anserine tendonitis and or bursitis, which I believe we'll figure of that on the next slide. So what's the management? Well, the big deal in runner's knee, if it's a tight IT band or some type of pes anserine tendonitis, the big deal is correcting the malalignment, just like we would in Patellofemoral syndrome. And then for this particular patient, you ice before, ice after activity, and making sure they have good warm-up and lots of stretching, specifically of the lateral muscles of the hip. And then some physicians will go in and inject the IT band distally with cortisone. But if you want to use a more conservative approach, of course, as always, NSAIDs work well. Now, in the case of a patient with IT band friction syndrome, what we tend to see is that this patient has like a leg length discrepancy. And so what we do is we refer them for orthotics, in which the podiatrist will go in and put in a heel lift to make the other leg the same length, and then what we see is a reduction in the signs and symptoms at the knee. So with IT band friction syndrome, what you see anatomically is the IT band starts up here as the tensor fascia lata, which we'll talk about when we get to the hip, so you don't need to know, but then it comes down and becomes a tendinous structure distally at the knee joint on the lateral aspect, and it's here in this place where if the structures around it are tight, so up here are tight, the quadriceps are tight, the patient starts to feel this sharp pain just above the joint line. And I've had patients describe it as a knife being poked into their knee, a needle being poked into their knee. They say it's out of a scale of 1 to 10, it's like it's a 9. They say it's really debilitating. It hurts when they're going upstairs. It hurts when they flex their knee, when they extend their knee. It hurts at end ranges of motion as well. And so even though you think, oh, it's just IT band syndrome, it's just runner's knee, I've had patients lose seasons for this particular pathology. Cortisone injection didn't work, taping didn't work, stretching didn't work, soft tissue didn't work. The only thing that actually worked was a surgical procedure called a lateral knee release. So with IT band syndrome, what is the etiology? Well, typically it's, like I just said on the other slide, it's a tight IT band that could be attributed to a leg length discrepancy. And then again, this can be fixed basically with orthotics and the podiatrist putting in a heel lift. But essentially what it is the most distal portion of the IT band, it inserts on the lateral femoral condyle. And so at the end ranges of knee flexion and extension, that IT band snaps over the bone. And so if it becomes inflamed, every time you flex and extend, as that tendon moves over the bone, it elicits or exacerbates the signs and symptoms and causes lots of pain. Now, if you have a tight IT band, it's a lateral structure. So it could potentially lead to Patellofemoral syndrome because of the maltracking that it might cause on the patella. And then essentially, if that patella is tracking laterally and it's wearing away on the lateral condyle, it could lead to bone softening or Chondromalacia. You most commonly see this pathology in your runners, number 1, cyclists, and then last but not least, your pronators. So with IT band syndrome, 2 things are important. 1, recognizing the signs and symptoms, and then number 2, managing it before it becomes so painful that your patient can't participate in sports. So the signs and symptoms, the big deal, like the differential, the go-to when you're asking a question is, where do you feel pain? And just like the box shows and the finger, the patient will complain of pain right here on the knee, the most lateral aspect of the knee, right in the joint line. And they will also have pain with an Ober's test. And an Ober's test is just that. It's a test of flexibility. So the patient basically lies on their side, and then you abduct the hip and then just let it drop. And in patients with tight IT bands, the hip won't drop because the IT band is so tight that it keeps the hip in hip abduction. So how do we manage a tight IT band before it becomes problematic, before it progresses to femoral pain syndrome, and or chondromalacia. Well, the big one is going to be stretching. So if you're listening to me talk, you're probably falling asleep by now. So my recommendation is to actually try this. And the leg that is actually being stretched is the leg that is behind the anterior limb. And so as you notice, you're leaning away from the side so that the IT band or the tensor fasciae lata specifically can be stretched. And then the other one that we recommend is the femoral, right? And then obviously the leg that is down and making contact with the femoral would be the leg that you are actually massaging. What you will find is that patients will report extreme pain for the first couple of weeks of foam rolling, and then progressively it gets better with time, and so you progress from a white foam roll to a black one, which is more rigid. These two treatment regimens alone have been responsible for reducing pain in patients and improving flexibility at the IT band. So we've kind of touched on Osgood-Schlatters disease, and we said Osgood-Schlatters disease is a disease that impacts the apophysis of the tibia, specifically with the patellar tendon pulling away from the tibial tuberosity. Well, the other end of that spectrum is what we call jumper's knees, which basically is quadriceps and or patellar tendonitis, right? And so how do you get patellar tendonitis or quadriceps tendonitis? Well, typically there's tension being placed on the quadriceps. That tension typically comes from jumping and landing with the knee flexed. It could be running, typically up hills, and or lots of repetitive kicking, right? So you're going a lot into knee flexion and knee extension. And so what we know about this pathology is that the patient typically reports pain, and that pain is typically sharp. They will most often be tender to palpation on the inferior pole of the patella if it's patellar tendonitis, and if it's quadriceps tendonitis, then they will be painful over the superior pole of the patella. Okay, most often than not, 95% of cases that you're going to see are going to be patellar tendonitis in nature. So remember, we talked about the 3 different grades of tendonitis or tendinopathies. Pain after activity would be sign and symptom of a grade 1, pain during and after grade 2, and then if they always have pain, then that's a grade 3, and we're concerned, right? Because that tendonitis is no longer tendonitis, probably tendinosis, right? That degeneration of the tendon. So how do we manage the tendonitis before it becomes a tendinosis? The big one is going to be, yes, your ice, your NSAIDs. The biggest one is honestly going to be the massaging, and then strengthening of the hamstring muscle groups, and strengthening of the quadriceps muscle groups if it is needed. What I found to be most effective with patellar tendonitis is definitely the heating and or therapeutic ultrasound of the tendon, where you're increasing blood flow to that tendon. So as stated, you could use NSAIDs. We said some cross-friction massage, some heating, icing, maybe even potentially. And one other thing that has been shown to reduce pain in patients with patellar tendonitis is a patellar tendon strap. And that patellar tendon strap is right here. And that basically goes about 2 finger widths below the inferior pole of the patella. And what it does is it compresses the tendon, and it takes some of the pressure off of that inferior pole of the patella. Well, if you don't have this fancy strap available to you, most people would know, at least if you're athletic and you've had patellar tendonitis, you can use pre-wrap to create this strap, and it's a lot cheaper, and it's kind of cool because there are different colored pre-wraps. So basically what you do is you wrap around the knee 5 or 6 times, and then you roll that pre-wrap. Guys, a little painful because it does pull the hair, but pre-wrap works just as effective as this patellar tendon strap. These straps will cost you anywhere from $5 to $10 depending on which store you go to, and most sporting goods stores will sell these. So your Big Fives, your Dick's Sporting Goods typically will have these on stock or in stock, and then we definitely have them downstairs in our clinic as well. So if you're looking at this and you're thinking, my goodness, this person definitely has increased range of motion. So one pathology about the knee is hypermobility, right? And so if we're looking at the patient on the left, and that patient has genu valgum, what we're saying is that that patient has an excessive amount of valgus at the knee. And well, some of the things, some pathologies that could arise from this type of hypermobility would be definitely increased chance of ACL rupture, definitely increased chance of MCL rupture, and then subsequently, because of the MCL association, medial meniscus pathology as well, right? A patient who has genu varum, which means increased angling at the knee, or what we would call a bow-legged individual. This individual has increased propensity for LCL pathologies and increased chances of a lateral meniscus injury as well. And then last but not least would be your what lay people would call the double jointed knee, or what we would call genu recurvatum, right? And this is the individual who has a hyperextended knee, and in which case they would be most susceptible potentially to ACL pathology as well, and then maybe even a hamstring pathology, because the hamstrings are on stretch constantly. Anytime you have a hypermobility in the knee, the alignment of the knee is thrown off, and as a result, anatomical structures are being stretched. And then the other thing to consider is that the kinetic chain is being altered, right? Forces are being distributed differently because of the hypermobility at the joint. In some sports, hypermobility would be a good thing. It would be beneficial. So we could take, for example, maybe gymnastics and or wrestling, where you want to be mobile. But in other sports, being hypermobile at the knee might actually be detrimental. And so we can think about sports with high velocities, like let's say your footballs and maybe your volleyballs. And so too much of something can be a bad thing, and too little of something can be a bad thing. So we really want to find the happy median. My rule of thumb within the knee is, if it's not broke, don't fix it, just like in the foot. So the last pathology that we'll discuss in the knee is the knee plica. What's interesting about the knee plica is that there are 4 different plica in the knee, and the only knee plica that really gets injured or irritated is the medial plica of the knee. And so that's what we're going to spend our time talking about during this portion of the lecture. So anatomically speaking, the medial plica basically attaches to the distal pole of the patella here, and then runs itself medially to attach to the posterior aspect of the medial femoral condyle. The role of the plica in the knee really truly is to kind of act like a bursa. So it's going to prevent friction of the quadriceps muscle anteriorly against the femur, and then posteriorly the popliteus tendon against the posterior femur. And so how does the medial plica get irritated? Well, it gets irritated from one of 2 reasons. Either you have this excessive amount of motion at the knee, specifically in knee flexion and extension. So we would see this most often probably in your long distance runners. So that would be either your cross country runners, your marathon runners, and your 10Kers, right? And then it can also get injured with a traumatic type of incident. So if someone knees the medial aspect of the knee, or if you get kicked, or I don't know, you should fall on the inside of your knee, the plica can get irritated. Now, when the plica gets irritated, what happens is it becomes thick. So it's kind of like the bursa. The bursa fills with fluid. In this case, the plica gets really, really thick. And when it becomes thick, that muscle rubs over it, and it causes more irritation, right? And so the number one sign and symptom associated with a medial knee plica would be pain, because every time that patient flexes the knee or extends the knee, that muscle's going to rub over the plica and elicit pain. The other thing that you get is a snapping and a popping sensation, and even it could be audible to the clinician. But that snapping and popping occurs because, again, as that plica gets thickened from the irritation and the swelling and the fluid. That tendon of the muscle will rub over it and cause a clicking and a popping. That is, again, either audible, and also you could potentially observe that clicking or popping. What patients also report is pain walking up and down stairs, and definitely during squatting. Again, that's because the quadriceps are very active during that time, and they rub over the medial plica. So I've seen this twice in my career. One time we literally just rested the patient, so they were removed from exercise. They could walk around campus, but other than just walking, they couldn't do anything. And so we iced, we compressed, we elevated, and the physician prescribed prescription strength drugs, and within a week the patient was back to participation with no pain whatsoever. However, in the second patient, we rested them for a week. They felt better, but then they returned to play, and a week later they still were complaining of pain. They still were having clicking and popping in the knee, and as a result they just could not participate because the pain was so intense. And so the physician recommended surgery. And so what the physician does is they go in and they shave down the plica, and in some cases they do what's called a plica release, where they actually cut the plica out of the knee. Now, interestingly enough, about 50 to 60% of the population has a plica, and the other 40% does not. So some of you don't even have a plica. Its only role, again, is to prevent friction, but again, we also have our bursa for that as well. So this is the end of the knee lecture. You guys should be getting ready to go into your exam. I am currently working on a study guide. So good luck in your exam this week, and then spring break is to follow. Thanks for listening to this lecture. If you should have any questions, please feel free to email me at NicoleCosby@pointloma.edu.